I think I'm actually relief for your brain in regard to cardiology. We're giving you a rest till you get the next set. So bleeding and coagulation, I have 30 minutes. It's very difficult to cover everything, so there are some extra slides in your handouts for a quick review so that for those of you taking board exams, you can at least run through that. So we'll try to hit those things that are most important. I don't have any conflicts. I will talk about some off-label use of agents, and I'll point those out as we go through. So often you have a case similar to this. 63-year-old post-bypass, 3 days ago, he's intubated still. Petechiae are noted below the blood pressure cuff, and he's oozing from the central catheter site, and he's got bloody secretions. Not an uncommon scenario. So the first thing I would suggest that you do is think about what is the defect in the coagulation cascade or with the platelets. So to do that, you need to actually do some history taking. Look at why was the patient in the ICU. In this case, the patient had surgery. Did they come in because they were septic? And that's going to help you as far as identifying potential conditions in the coagulation arena. Now, the type of bleeding may also help point you to a specific defect. So mucosal bleeding, petechiae, and bleeding that occurs immediately after an incision or puncture suggest a platelet abnormality, while visceral deep bleeding that is delayed suggests a coagulation cascade issue. You need to take into account there are other medical issues, any drugs, are they on anticoagulants, and then you're going to use your laboratory test to support, hopefully, what you're already considering. So for assessing platelets, of course, we get a number with our platelet count. If on a board exam you're given a peripheral smear, you count the platelets, multiply them by 10 to 20,000, and that'll give you an estimate of the platelet count. When it comes to platelet function, we don't have great tests. We really don't use bleeding times anymore. In some specialized centers, you may have platelet aggregation tests available, but that is not routine. For the coagulation cascade, you're going to look at your prothrombin time, your partial thromboplastin time, which are our mainstays, and that will tell you about deficiencies of factors. Thrombin time would be a low or abnormal fibrinogen or a thrombin inhibitor. So if we're not sure whether we're dealing with a deficiency or an inhibitor, then we will do mixing studies. Now, part of clotting is the unclotting, if you will, the fibrinolysis. So here we use D-dimer and the fibrin degradation products. Now, D-dimer is actually more specific for breakdown of clot because it only comes from breakdown of cross-linked fibrin, whereas fibrin degradation products come from fibrinogen as well as fibrin. So D-dimer is more specific for breakdown of clot. Now, I want to mention thromboelastography, or you can also put in thromboelastometry, the rotational thromboelastometry in this category. And the surgeons may talk about that more in their session this afternoon. It provides an overall picture of ex vivo coagulation, clot formation, onset, the velocity of clot formation, the amplitude, as well as lysis. So it tells you about platelet function and fibrinolytic activity. The studies so far have correlated some of these values with mortality and morbidity, but currently there's no good evidence that they are superior over our conventional test. What it does suggest is that if these tests are being used, there's going to be more transfusion of platelets and cryoprecipitate than blood or fresh frozen plasma. But again, there's no evidence that outcomes are improved over conventional testing. Let's start with platelet abnormalities. We know that if you come into the ICU with a low platelet count, develop a low platelet count, or fail to increase your low platelet count, that's a sign of a poor prognosis. So it's important to try to treat the underlying problem. And as you know, you learned this in medical school, platelets are either going to be produced or not. If platelets are not being produced, we've got a marrow problem. And that could be infection, it could be a malignancy, or often it's one of our drugs, including our chemotherapeutic drugs, as well as recreational drugs such as alcohol. The other possibility is that the platelets are being produced, but they're being destroyed. And in this case, we have two options. It's either an immune destruction or a non-immune. And just to be complete, we'll put the sequestration in there, splenic sequestration. So when you look at thrombocytopenia in the ICU, the top causes, probably the top three here, sepsis, DIC, and massive blood loss. Now, in your individual patient population, it's going to vary depending on if you're a trauma unit or a medical unit. We also need to consider drug-induced, heparin-induced thrombocytopenia, and probably less common would be your immune thrombocytopenias and the thrombotic microangiopathies that can occur. Now, just a few words about drug-induced thrombocytopenia. Again, it can be immune here or non-immune. It's a clinical diagnosis. Trying to do antibodies to drugs is fraught with a lot of problems. It may be negative because the antibody may be actually directed at a metabolite of a drug rather than the drug itself. Usually this will occur anywhere from 5 to 7 days after exposure to a drug. It may be delayed a little bit more if the exposure is intermittent. One of the hallmarks of drug-induced thrombocytopenia is a very low platelet count. So if it's less than 20,000 and if there's a rapid decline, you should be thinking about a drug-induced thrombocytopenia. If you can identify the drug and stop it, the platelet count will normalize usually within about a week. It depends a little bit on the half-life of the culprit drug, however. Now, when you think about what drugs that we expose our patients to, these are a list. Iodinated contrast media will actually cause this, and it's something you may not be aware of. So again, it's a one-time exposure, so it's fairly transient. Seizure medications, H2 blockers, this is probably an over-reporting of thrombocytopenia with these drugs, and this is thought primarily to be kind of a non-immune. It's a suppression of the bone marrow rather than an antibody-mediated phenomena. All of our new monoclonal antibodies that are being used in therapy, rituximab, infliximab, any of the MABs can be associated with thrombocytopenia. And again, more and more of our patients are exposed to these. When it comes to antibiotics, it used to be the list was cephalosporins and penicillins. Now it's vancomycin is probably the number one. And vancomycin is an immune-mediated thrombocytopenia. The antibody will bind to platelets as long as vancomycin is present. If you stop the vancomycin, it's metabolized, the platelets count will come up. Now, linezolid, usually the thrombocytopenia occurs after longer-term use, and this is thought to be a non-immune thrombocytopenia, not related to an antibody. So those are all things that you need to consider in your patient. This is a good website, which is on your slide, if you want to look up all the causes, all the drugs associated with thrombocytopenia, and they actually also list the probability. Treatment really depends on the etiology. So if you have defective production or non-immune destruction, the bottom line is treat the underlying etiology, stop a toxin if it's present, and then we support with platelet transfusions if needed. Now there's really two approaches. Therapeutic, we transfuse platelets only when they have bleeding, or we give prophylactic platelet transfusions because we're worried about the risk of bleeding. Now in the ICU, the majority of platelet transfusions are administered for prophylaxis rather than therapeutic approach. What is the threshold for transfusion? Well, this depends on your patient. You have to do a risk assessment in these patients. In a relatively stable patient, the recommended threshold is about 10,000. Now, the American Association of Blood Bank just released some of their guidelines, and what they say is for hypoproliferative marrow, then this is the threshold. And that's because all the studies were done in cancer and hematologic malignancies. We've extrapolated that to other patients. If you have a bleeding patient, we typically say 50,000 is where we would like it. If you have a neurosurgical patient, then it may be more likely to be 100,000. So you have to use that insight and your judgment to determine that threshold. Now, the dose of platelets, it's interesting, over my career, we used to give 10 packs of platelets, then it became the 6-pack. It's actually now the most common number of platelets transfused is 5, and that's because our yield from our donors is much higher. The single donor platelets, which in our institution is almost, I believe, 80%, is one we call jumbo unit. You may have different terms. So more and more you'll see these single donor units. Keep in mind that in the ICU, the studies and your experience, I'm sure, will tell you that you can transfuse platelets and only about half of the time will the platelet count actually increase significantly. And there's many factors for that that you have to account for. So keep that in mind, because many times giving more platelets when that occurs doesn't really buy you much. And again, platelets are our most precious commodity in our blood banks. Immune thrombocytopenias, the mainstay, of course, is steroids. Some people will give very high doses if you have very severe thrombocytopenia and they are high risk of bleeding. Keep in mind the IVIG that you could use to increase platelet count transiently. This has shown up on board exams in the past. It is transient, but you can, if you need to take someone to surgery, give them IVIG and get that temporary effect. Anti-D can be used in patients who are Rh positive. They have to have a spleen as well. Keep in mind that immune thrombocytopenia has been associated with H. pylori and hepatitis C. And in many cases, treatment of the underlying disease will actually result in resolution of the thrombocytopenia. When do you transfuse platelets? Really only for severe bleeding. And the only recommendation that people have is that if you are caught in that circumstance, you will have to give more platelets than you anticipate, which kind of makes sense. They're going to be exposed to the same environment of that antibody. More and more we're seeing rituximab being used. It is approved for chronic or refractory ITP, but I'm sure you may be seeing it used earlier. Recent study didn't show any difference when this was given or not given. The other thing that's approved for chronic ITP are the thrombopoietin receptor agonists, romaplastim and eltrombopag. I always have trouble saying that one. Less and less we're seeing splenectomy or a lot of these other chemotherapeutic agents because we're hitting them harder with rituximab and some of these other agents up front. Again, most of these patients with immune thrombocytopenia don't end up in an ICU, but if someone has this and then has a hip fracture or is involved in a traumatic accident, then they may show up in your ICU. First question for you, we're going to look at the information, I'm going to show you a peripheral smear, and then you're going to answer the question. So you have a 32-year-old who comes in with headache, fatigue, mild confusion. Blood pressure 120/76, pulse is okay, respiration's okay, temp 99. You have your labs there, and these are obtained before a head CT is performed. White count 6,000, platelets low, 18,000. PT, PTT look normal. You have your electrolytes, and BUN, creatinine are abnormal. So here comes the peripheral smear. Okay, I don't know how that shows up in your book, but this is what it will look like. And for those of you on taking medicine boards, they always like to give you a smear, not necessarily for this, but for something. Okay, so let's go back and ask the question. Which of the following is the most appropriate intervention? Lumbar puncture, transfuse platelets, transfuse FFP, or give ceftriaxone? Okie dokie. Well, the correct answer is to transfuse FFP. This is thrombotic thrombocytopenic purpura. The key here is you have thrombocytopenia, your other coagulation parameters okay, you have renal insufficiency, you have CNS effects, and you have a low-grade fever. So the smear is very helpful here because here are your schistocytes, so that gives you the diagnosis of a microangiopathic hemolytic process. This is a reticulocyte, so the marrow is trying to produce more red cells. And what you don't see on this smear are platelets. There are no platelets whatsoever on this smear. So those are the key features. So TTP, we now know the etiology, it's lack of the metalloprotease, so that the von Willebrand factor is not broken down, and these long von Willebrand factor fragments are very prothrombotic, cause platelet aggregation. Although we used to say the pentad, all you need is, for diagnosis, is the first two, thrombocytopenia and a hemolytic anemia. Because many times we're picking this up earlier, I think, today than we did 10 and 20 years ago, so these other manifestations are not always present. Now, the treatment you know, which is plasmapheresis and FFP. What are we doing? Well, plasmapheresis is taking away the antibody that affects this metalloprotease, and FFP is actually replacing the metalloprotease. Now, if you can't do plasmapheresis immediately, then what you should be doing is giving FFP to these patients until plasmapheresis can be initiated. Steroids are given for these antibody formation, and rituximab is being used when you have usually a poor response to the initial plasmapheresis, and that is an off-label use. We are a referral center for TTP patients, and our hematologists are using rituximab sooner than later in these patients. Red cell transfusion, if they need it, we usually let them go down a little bit lower before we give anything. What you don't want to do is give platelets. That is contraindicated. So if you're thinking TTP, don't give platelets. We follow the platelet count, we follow the LDH for hemolytic process, and of course the hemoglobin as a sign of your therapeutic interventions. Now I want to mention hemolytic uremic syndrome as well, more typically seen in children, and they're both typical and atypical. So the typical is the one associated with the Shiga toxin producing E. coli. Atypical is where it's not associated with the E. coli. Basically, this is a hyperactivation of the complement cascade. So it's something either genetic or more likely acquired, which is often an antibody. And the difference between this and TTP is more renal dysfunction and the diarrhea. There's less CNS manifestations with HUS. Treatment is very similar for the typical, which is plasma exchange, plasmapheresis. You may need dialysis. If it is an atypical HUS, then eculizumab is now approved therapy. It's very expensive therapy, so you want to make sure you've got the right diagnosis. But basically, this is an anti-complement 5 antibody that is used in this disorder. Heparin-induced thrombocytopenia, this is always something we think about when we see thrombocytopenia. It's probably, we overdiagnose or think about it perhaps more than we actually see it. But again, it's an IgG antibody directed at platelet factor 4. It occurs with any form of heparin, unfractionated or low molecular weight. If they're on heparin, the recommendations is that you monitor with your platelet counts, which most of us are doing anyway in the ICU, and that heparin be discontinued if you see the platelet count fall to less than 50,000 or if it decreases by 30 to 50%. Even if it's still normal, you need to be thinking about that drop being a manifestation of HIT. Bleeding is actually very rare. This is actually a thrombotic disorder, not a bleeding disorder. So thrombosis is often or may be a presenting clue rather than the platelet count. So keep in mind, thrombosis can occur before the platelet count goes down. So if you have someone on heparin who has a thrombotic event, you're going to have to stop heparin and think about something else in those individuals. And this is distinguished by the fact that you do get arterial as well as venous thrombosis, although venous is more common. Risk assessment is important when you're thinking about this because we know that cardiovascular orthopedic patients are more likely. ICU patients, that's all of ours, I guess. Women develop this more than men. It's more common with unfractionated because it's a longer heparin, and the longer the heparin, the more it binds to platelets. Full dose anticoagulation is more likely to cause this than prophylactic doses, and the longer you treat your patient, the more the exposure and the greater the risk. The diagnosis is difficult. The gold standard is actually a functional assay of platelet aggregation. This is often a serotonin release assay. Now, most hospitals won't do this type of test right off the bat. What you usually get is the antigen assay, the ELISA, for anti-platelet factor 4 antibodies. It's sensitive, but it's not specific. And if you actually did this test on your cardiac and vascular surgery patients, it's been shown that more than up to 50% will be positive. So in some places, they'll use this as a screening and then go on to do a platelet aggregation. But you still have to use your clinical judgment and put it back in the context of what's going on with the patient. The HIT kind of scoring is there in your chart for your review. I will tell you there's a recent study showing it doesn't work well in ICU patients, which is probably not surprising, but that is there for your review. So let's go on to the next question here. You have a patient with a previous MI and ESRD who's being treated for PE with unfractionated heparin. Day 5, the left foot is cold, no popliteal pulse, platelet count went from 250 to 100,000. Probably not a big, this is not a diagnostic dilemma here. After heparin is stopped, which of the following agent is indicated? Fondaparinux, bivalirudin, argatroban, warfarin, or a GP2B3A inhibitor? Okay, got that? Argatroban is the agent that you would use at this particular point in time. So you have to use an alternative anticoagulant. Argatroban is FDA approved. Bivalirudin is actually approved for use in patients with HIT in PCI. Fondaparinux has been reported to be used. It is not approved, and there are some cases of HIT actually reported with use of fondaparinux. Fondaparinux is also not a great drug for our ICU patients because it's long half-life and it's renally excreted. So argatroban would be the answer. It is recommended that even if there is no thrombosis that you anticoagulate these patients because the risk lasts for several weeks. So the recommendation is 2 to 4 weeks post-diagnosis of HIT. This is another condition where you would only consider platelets for severe bleeding. Warfarin should not be instituted until the platelet count returns to normal, if that's the anticoagulation that the patient needs. Okay, another question. 30-year-old presents with altered mental status, fever, skin lesions that you see here. There's no bleeding, blood pressure's okay, heart rate's elevated. You see your platelet count's low, PT, PTT prolonged, hemoglobin low but okay, white count 18,000, creatinine 2.3. So the question is, which of the following is most appropriate after antibiotics are started? Transfusion of platelets, transfusion of FFP, factor 7, blood, or nothing? Okay, good. I would agree. No transfusion is needed. This patient is not bleeding. She does have coagulation abnormalities that are consistent. This was actually a meningococcal bacteremia patient with the typical purpuric lesions that you see here. DIC is very common in our ICU patients when we diagnose it by laboratory parameters. But remember, this is still a clinical diagnosis. You have to have a condition present that is associated with DIC, and then you add into that your laboratory exam. Most of the time, we rely on a PT, PTT, platelet count, and some evidence of clot lysis, such as D-dimer. Fibrinogen may also be low, but since it's an acute phase reactant, I rarely see that. Helps me a lot. But again, remember, it's a clinical diagnosis. You can do other testing, but none of these tests are specific. It is truly a clinical diagnosis. And the treatment is the one you hear, treat the underlying condition, which is true. Transfusion should be reserved for significant morbidity. So they're bleeding or they may need an invasive procedure. And then you would support them with blood products. What you should not do is treat laboratory numbers, okay? They don't need transfusion in many cases. So the blood products we'll just review real briefly. Fresh frozen plasma. Dosage, we often underdose our patients when they actually need it. Often we start with 2 units of FFP or 1 single donor pheresis unit. That may or may not be enough. Keep in mind that if you're also transfusing platelets, 5 to 6 units of platelets actually equals 1 unit of FFP, except for factor 5 and factor 8. Typically, you're going to follow the PT, PTT, and if someone's actually bleeding and needs FFP, remember that you have to dose it every 6 to 8 hours because the half-life of factor 8 is very short. Keep in mind also that if the INR is less than 2, it's unlikely that you're going to change that number with FFP. The actual INR of a bag of FFP is 1.5 to about 1.7. So you can understand how that can occur. Cryoprecipitate, the way to think about this is that it's a source of fibrinogen. Although it does contain von Willebrand factor, we don't really use it for that anymore. The indications for cryoprecipitate are a low fibrinogen level. Now, traditionally, we've used a threshold of 100 milligrams per deciliter, but now in trauma and some of the obstetric literature, they're using cryoprecipitate at thresholds of 150 to 200. So you'll depend a little bit on your practice and your patient. Usually, most of us start with 10 units because it's easy to remember 10. So you order 10 units of cryoprecipitate. Now, another treatment of DIC using heparin, that's very controversial. I would say probably the most common reason if you're going to think about this is when you have DIC with overt thrombosis. These other ones are on the list. There's no good evidence. Even our hematologists don't routinely give heparin to promyelocytic leukemia patients. They wait till they have evidence of DIC. Fibrinolytic inhibitors, not really. This is hard to do. This is a clotting disorder, and you don't really want to make that even worse. So I can't say that that's something you should do. Now, topical fibrinolytic inhibitors are often used in these patients for mucosal bleeding. Coagulopathy of trauma and massive transfusion, difficult topic. The surgeons will have their views on this. It's a little bit different in some of our massively bleeding medical patients, but basically it's defined as bleeding from the mucosal serosal surfaces, vascular access site, and it's really a multifactorial hemostatic defect due to things such as hemodilution, acidosis, hypothermia, and then DIC as well, which is associated with more severe injuries and also hypotension in these patients. The overall goal is the one that we have for all our patients, which is to maintain perfusion and oxygen delivery. Now, you're probably aware of the CRASH-2 study. There's a lot of still some controversy I hear from my surgeons, and probably the key here is early use of tranexamic acid in these patients. There's other studies going on. Dysfunctional or low platelet counts, you give platelets. Factor depletion, again, we replace with FFP, cryoprecipitate for fibrinogen. And then we come to the issue of blood product ratios. Up until recently, most of the studies have been retrospective before-after studies that suggested better outcomes with lower ratios using more FFP, more platelets. And there was a concern of survival bias impacting outcomes, and that's still true. The other thing I always have difficulty with is which ratio. You'll see various things, 10 platelets to, or transfused platelets for 10 units of red cells, or FFP is 2 red cells, 1 FFP, or it's 1 to 1. So all the studies are somewhat variable. The most recent study is the PROPER trial, which was, I think it was in JAMA in February of this year, where they compared a 1 to 1 to 1 FFP platelets red cells to a 1 to 1 to 2. They found no difference in mortality at 24 hours or 30 days, but there was fewer deaths from exsanguination in the first 24 hours in the 1 to 1 to 1. So I think we still don't have an answer as far as definitively how this is impacting patient outcomes, but we should have more in the near future. I mentioned von Willebrand's disease because it's the most common inherited disorder that you might see. It's usually picked up incidentally with a prolonged PTT. There's 4 different types. The most common is the impaired release of von Willebrand factor, which DDAVP will help. The other thing is we no longer use cryoprecipitate, as I mentioned here, but factor 8 concentrates. These contain 8 plus the von Willebrand factor, so you'll need to check with your hospital hematologist blood bank to find out which product you have that has the higher von Willebrand factor. There's also acquired von Willebrand disease. It's associated with lymphoproliferative, myeloproliferative disorders. and also interesting cardiac defects such as VSD and endocarditis. And it may be related to an antibody, so IVIG has been proposed as an option for treating these individuals. For the hemophilias, the bottom line is the most important. Call your hematologist. Again, we have factor VIII deficiency, factor IX, we have concentrates, but the dosing can get very tricky because you have to increase dosing if they have active bleeding. If they have inhibitors, this is the one approved indication for factor VII or some of the prothrombin complex. But again, call your hematologist when dealing with these patients. Warfarin-related bleeding, always think about this when you're administering drugs to your patients who are on warfarin. We keep in mind that it's not just a prolonged prothrombin time, but also a prolonged partial thromboplastin time, depending on how the dosing and the interactions occur. Now, if they have bleeding or high risk of bleeding, you may want to reverse those effects, and often we used FFP, but now we have approval of some of the prothrombin complex concentrates that can be used as well. The problem with these is that they are prothrombotic. The advantage is it's a smaller amount than FFP, so you don't have as much volume overload problems, and you don't have to thaw them out. So these can be used, and obviously if you're going to reverse with vitamin K, but that takes 12 to 24 hours to have an effect. And often in these cases, if they're not bleeding, you're going to use heparin to bridge for anticoagulation. Then I want to kind of end up with some of the antiplatelet issues that we face today. Perioperative bleeding has not been shown to be increased with aspirin. It has been shown to be increased with clopidogrel. However, some of the study findings have been variable. Management is preventative. If you can stop these drugs 5 to 7 days before surgery, if they bleed, you might consider platelet transfusion. We actually have no evidence that that makes any difference. In the platelet guidelines from the American Association of Blood Banks, they could not recommend even for or against platelet transfusion in this circumstance with intracranial hemorrhage. We just don't know that it makes a difference. I think it makes us feel better because it gives us something to do when we have these life-threatening bleeds. The oral thrombin inhibitor, dabigatran, remember this is renally excreted. It has a short half-life, and theoretically, we shouldn't have bad bleeding problems, but when you have this drug being given to people with renal insufficiency, it sticks around quite a while. There is no reversal agent currently approved, but they are moving through with FDA approval with a monoclonal antibody fragment. But if you're given this on a board exam and someone has life-threatening bleeding, remember this is a dialyzable drug. So if anything, you might dialyze. FFP, factor VII, not recommended. They don't work in this setting. Now, what about the 10A inhibitors, rivaroxaban? It is renally excreted. It is not dialyzable. In healthy individuals, it has been shown to be reversed by the non-activated 4-factor prothrombin complex. There's also animal studies. Apixaban, not dialyzable either. Again, some studies suggesting it might be reversed by some of these prothrombin complex concentrates. None of these are approved at the present time for these situations, but keep in mind that this might be reasonable for life-threatening bleeds in this circumstance. So I'll stop there on bleeding and coagulation.